Golden notes. Achalasia. When the dysphagia affects both solids and liquids from the start, we should always think about achalasia. What is the achalasia? It is characterized by a hypertonic lower esophageal sphincter which fails to relax in response to the swallowing wave. Failure of propagated esophageal contraction leading to progressive dilation of the gullet. It is due to degenerative loss of ganglia from Auerbach plexus. However, the cause is unknown. The result will be the lower esophageal sphincter contracted, whereas the esophagus above is dilated. In fact, there is something interesting that loss of the dorsal vagal nuclei within the brainstem can be demonstrated in later stages. Infection with Trypanosoma cruzi in Chagas disease can cause a syndrome that is clinically indistinguishable from achalasia, typically present in middle age, equally common in men and women. Clinical features. In fact, the presentation is with dysphagia. This develops slowly, is initially intermittent, and is worse for solids and eased by drinking liquids and by standing and moving around after eating. Heartburn does not occur because the closed esophageal sphincter prevents gastroesophageal reflux. Some patients experience episodes of chest pain due to esophageal spasm. As the disease progresses, dysphagia worsens, the esophagus empties poorly, and nocturnal pulmonary aspiration develops. In fact, achalasia predisposes to squamous carcinoma of the esophagus. So symptoms usually develop years before the patient presents. Dysphagia of both liquids and solids, typically variation in severity of symptoms, heartburn, regurgitation of food, may lead to cough, aspiration pneumonia. Vague chest discomfort is common and results from esophageal spasm. Nocturnal cough, 30% due to aspiration of esophageal contents. Investigations. Endoscopy should always be carried out because carcinoma of the cardiac can mimic the presentation and radiological manometric features of achalasia. The pseudoachalasia. A barium swallow shows tapered narrowing of the lower esophagus, and in late disease, the esophageal body is dilated. Can be also peristaltic and food-filled. The manometry confirms the high pressure, non-relaxing lower esophageal sphincter with poor contractility of the esophageal body. So let's organize the ideas. The gold standard test for achalasia is esophageal manometry. Barium swallow, it is the initial investigation, will show dilated esophagus, fluid level, and bird's beak appearance. The manometry, considered most important diagnostic test, indicated to establish the diagnosis, confirmatory test of choice. Irrespective of the initial imaging findings, can detect achalasia in the early stage before esophageal dilation has occurred. Will show excessive lower esophageal sphincter tone, which doesn't relax on swallowing, lack of peristalsis in the lower two-thirds of the esophagus. Upper endoscopy to rule out pseudoachalasia, usually normal, but may show retained food in esophagus or increased resistance of low esophageal sphincter during passage with endoscopy. CXR will show wide mediastinum with a width greater than 6 cm on an upright posterior anterior chest X-ray or more than 8 cm on supine anterior posterior chest film. CXR may show also fluid level. We should remember that the most appropriate initial investigation of a high dysphagia is a barium swallow, which identifies the site of pathology and forewarns of pitfalls such as pharyngeal pouch, which, if unidentified, can increase the risk of perforation at endoscopy. Treatment: halar cardiomyotomy, laparoscopic myotomy, the best initial treatment for most patients with achalasia. Balloon dilation, pneumatic dilation, the most cost-effective alternative. Long-term efficacy is less than that of surgical myotomy, the preferred option for older, unfit patients. Pneumatic dilation is currently the most effective non-surgical option for treatment of achalasia. The current guidelines recommend obtaining gastrography study followed by barium esophagram in all patients after pneumatic dilation to exclude esophageal perforation. 25% of patients treated with pneumatic dilation required a redilation. Intrasphincteric injection of botulinum toxin. In fact, the botulinum toxin injected into the lower esophageal sphincter reduces the pressure and provides symptomatic relief better than other drug therapy. However, the effects are temporary and patients need to undergo repeat injections every 6 to 12 months. Endoscopic botulinum toxin injection can be considered when other forms of treatment are contraindicated, reserved for the elderly and who cannot tolerate dilation or surgery. Drug therapy has a role but is limited by side effects. Short-term improvement in clinical symptoms may occur with isosorbide mononitrate, a long-acting nitrate, or with nifedipine, which is a calcium channel blocker. The contraindications: promotility agents like metoclopramids increase the lower esophageal sphincter pressure and so are contraindicated in achalasia. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. Remember that the Golden Notes references and sources are Davidson Oxford Handbook Series, Essential Revision Notes for Mrcp, and Notes and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. And remember, with SSSM, you're always in a safe zone and you are always the winner.